The topic on which I will be speaking is challenges and best practice for managing anemia in non-dialysis chronic kidney disease patients. So, as we all know that chronic kidney disease is a big burden, global burden, because with a prevalence of approximately 10%, one in every 10 people is having any form of chronic kidney disease. And as the chronic kidney disease progresses, then the severity of complication increases. And as we can see that in the last uh, from 2013 to it is projected that up to 2040 there will be a 41% increase in the death due to chronic kidney diseases, and in 2040 it is projected that it will be CKD will be a fifth leading cause of death. Now, chronic kidney disease risk factors we know are female sex, elderly population, individual with diabetes mellitus, hypertension, and even diabetes has become one of the most important cause of CKD nowadays. And India being a diabetic capital, so the burden of this morbidity is increasing day by day. So today we will be speaking in anemia and chronic kidney disease. And anemia and chronic kidney disease develops when the GFR decreases to less than 60 ml per minute per 1.73 meters square. It is a common complication of CKD, and its severity increases as the CKD progresses from stage 1 to stage 5, and it leads to reduced quality of life, worse renal survival, and it also increases the mortality and morbidity in patients as well as the cost burden to the society. So we need to address this issue very efficiently and at an early stage. So what is the prevalence of anemia and chronic? Approximately 40% of the patients with stage 3 CKD are having anemia, which increases to 70% when the patient reaches CKD stage 5. And at least 90% of patients requiring dialysis develop anemia of CKD. Hemoglobin levels in adult males and in adult females less than 12 are considered to be anemic. Anemia in CKD stage 3, the prevalence is 5.2%, it becomes 44% in CKD stage 4. And in CKD stage 5, it is almost universal, means every patient will be having some form of anemia, either mild, moderate, or severe. So, what is the mechanism? What is the mechanism how the anemia develops in a patient of CKD? So, there are multifactorial mechanisms. The most important one is the progressive reduction in the erythropoietin levels, which is produced in the kidney interstitium. Absolute iron deficiency due to blood losses or an impaired iron absorption. Ineffective use of iron stores due to increased hepcidin levels. Systemic inflammation due to CKD and associated comorbidities. Reduced bone marrow response to erythropoietin due to uremic toxins, and reduced red cell lifespan. Other causes are like vitamin B12 and folic acid deficiencies, and some form of infections in a chronic kidney disease patients, maybe tuberculosis or other bacterial infections. So these all multifactorial mechanisms leads to anemia in a chronic kidney disease patient. Now, what are the common symptoms? How the patient presents to a physician or nephrologist? So the common symptoms of anemia are dyspnea, fatigue in doing a normal household work, headache, dizziness, generalized weakness, decreased concentration ability, reduced exercise tolerance, and there are some signs which the physicians make out in a patient having anemia. These are pallor, skin and conjunctival pallor, respiratory distress, tachycardia, and in some chronic anemic patients may lead to heart failure. So anemia in a chronic kidney disease patient, what are the outcomes? So there was an observational study which studied approximately 28,000 of patients, and they compared patients who died and patients who survived. So in the patients who died, they found that there were higher baseline prevalence of anemia, higher prevalence of diabetes, and the patient who survived, there was a higher prevalence of coronary artery disease because they were anemic, and when they survived, they finally had congestive heart failure and some form of cardiovascular involvement in the form of coronary artery disease, and the greatest increase in the prevalence of anemia over the observational period. The anemia increased in those patients over the time, those who survived. And there is a retrospective study of patients with incident CKD who were diagnosed just freshly diagnosed CKD, incident CKD. So in that, what conclusion they drew was anemia was a predictor of excess cardiovascular hospitalizations and excess ESR. The second was anemia was a predictor of excess mortality. An increased rate of mortality, cardiovascular hospitalizations, and ESRD in those with most severe anemia versus non-anemic patients. So, what are the causes of iron deficiency in a chronic kidney disease patient? In a chronic kidney disease patient, the causes of iron deficiency are either some type of chronic blood loss during, and second one is the decreased absorption of iron from the gut. So, this iron deficiency is highly prevalent in CKD patients. Higher prevalence of functional iron deficiency subtype in patients with advanced CKD, and it doesn't vary with the CKD stage. I mean, all the stages you will find some degree of anemia and iron deficiency. So, what about the anemia in non-dialysis CKD patients? Because in dialysis CKD patients generally there is some type of blood loss from AV excess during dialysis. These all leads to anemia, various degrees of anemia in the patients who are undergoing dialysis. But in non-dialysis CKD patients, up to 60% patients with non-dialysis CKD develop anemia, and 50% of these are having iron deficit. So this anemia has poor outcome in patients with non-dialysis CKD. They affect quality of life and worse quality of life in those with hemoglobin levels less than 11 gram percent than those with hemoglobin level more than 11%. Now, anemia in non-dialysis CKD patient, there was a single center study in India. It was studied in non-dialysis CKD patient. Approximately 600 patients were studied, and there were CKD stage 3, 4, and 5. And the mean hemoglobin level in the stage 3 was 9.9, 4 was 9.4, and 5 was 8.4. So overall, there was around 9. And it was seen that there was a progressive fall in the hemoglobin level as the CKD severity increases. And as the CKD progresses, CKD severity increases, the hemoglobin level comes down, and there was a significant positive correlation of hemoglobin with the EGF. So the distribution of anemia severity categories, there was a mild anemia in 31% patient, moderate in 47%, and severe anemia was found in 21% of patients. And it was concluded there was a worse outcomes with anemia in non-dialysis CKD patients. Reports from chronic kidney disease outcomes and practice pattern study CKD and it showed that there was negative association of lower hemoglobin with CKD progression and all-cause mortality. And there was analysis of 4 community-based longitudinal studies. They showed that anemia was associated with 50% increase in the composite of myocardial infarction, stroke, and all-cause mortality. Now, evolution of anemia management. Now will talk about the anemia management in CKD patient, and it evolved over the years. Because initially in 1830s, the first oral iron supplementation in the form of ferrous sulfate was discovered, and after that there was the role of blood RBC transfusions, blood transfusions. After 1980s comes the first recombinant human erythropoietin use, and In recently, we are having some long-acting ESAs like darbepoetin, Mircera, and finally, the widespread use of intravenous iron supplementation. So the actual management of anemia in patients with CKD varies among different countries and medical units, and every unit is having a different protocol how to manage anemia in a CKD patient. So management of anemia in non-dialysis CKD. It has having three options: short-acting and long-acting erythropoiesis stimulating agents, oral and IV iron formulations, and red blood cell transfusion. Optimal targets of hemoglobin, transferrin saturation, ferritin remains unknown, and they may vary according to the various therapeutic approaches at various different centers. So the critical practice guidelines for anemia in management of anemia in CKD. Current guidelines of KDIGO, ERBP, NICE do not fully coincide with each other. Some controversies exist about the optimal hemoglobin and iron targets. So the NICE study, they diagnosed how they diagnose iron deficiency. They tested patients every 3 months, 1 to 3 months in hemodialysis patients, and a combination of serum ferritin less than 100 and T-cell less than 20% was said to be a marker of iron deficiency. The treatment decision was correct iron deficiency before ESA therapy. Target hemoglobin was 10 to 12 gram percent, and the target objectives were avoid serum ferritin above 800. And as far as iron therapy is concerned, non-dialysis CKD with anemia and iron deficiency offer a 3 month trial of oral iron therapy. If it fails, then offer IV iron therapy. In dialysis-dependent CKD, preference was given to IV iron, and if IV iron, consider high-dose, low-frequency formulation for non-dialysis and dialysis-dependent CKD patients. Same with KDIGO guidelines of 2012. They made the diagnosis of iron deficiency as serum ferritin less than 100 and T-set less than 20%. And treatment decision was a trial with IV iron was given. And in non-dialysis CKD patients, the hemoglobin, if it is less than 10, then the treatment was initiated. Even in dialysis CKD patient, if the hemoglobin is between 9 to 10, then the treatment is initiated. And the target hemoglobin was 11.5 gram percent. And stop iron supplementation if serum ferritin levels rises above 5. Same in non-dialysis CKD, first given oral iron, and in dialysis dependent preference for IV iron is given. Now, talking about what are the different types of erythropoiesis stimulating agents. The first EPO analog was epoetin alpha and the next was epoetin beta. Developed later darbepoetin alpha DA and the methoxypolyethylene have prolonged half-life, that is Mircera. Recent have some biosimilars of the original epoetin have come. All ESAs are not equal. Different pharmacokinetic and pharmacodynamic properties such as different half-lives and EPO receptor affinity. All ESAs are not equal. Allow a less frequent dosing and ease of administration for non-dialysis CKD patients with long-acting ESA. Means long-acting ESAs are those that are Mircera or darbepoetin. They should be used for maintenance therapy and less frequent use of injector. Now ESA, patient-rated outcomes. The effect of achieving hemoglobin normalization with ESA remains controversial. Recommendation for ESA initiation is that initiate therapy in selected patients with non-dialysis CKD when the hemoglobin falls below 10, and considering the factors such as hemoglobin decline, risk associated with ESAU, risk for blood transfusion, and presence of symptoms. So less than 10, you can initiate an ESA in non-dialysis and in dialysis CKD patients. Now there are various trials which individualize hemoglobin target according to patient profile, and there are the core trial, plate trial, and tree trial. And in these trials, the target hemoglobin levels were different. Core it was 13.5, plate it was between 13 to 15, and tree it was 13. So, what is how to individualize the hemoglobin target according to patient profile current evidence? First is the benefit correcting hemoglobin levels if they are below 10, increased risk when exceeding 13, and target to be between 10 to 12. So When it falls below 10, you should treat it, initiate it, keep it between 10 to 12. But if it rises more than 13, there is a risk for some cardiovascular complications in patients or some AV fistulas, thrombosis, and all that should be avoided to rise the hemoglobin levels above 13. Now I comes to iron supplementation, which is important because if there is iron deficiency, first it should be corrected and then we can move to the ESA. What are the benefits of iron supplementation? Benefits are both in dietary dependent and non-dietary dependent CKD patients. More efficacious in rising ferritin and hemoglobin levels and reduces ESA and transfusion requirements. This is a fine CKD study and the outcomes were that 35% lower risk of time to initiation of other anemia management in higher ferritin groups versus poorer iron groups. And there was no difference in groups with respect to CV events or infections. So it remains to be determined if the strategy delineated in the fine CKD study is beneficial in terms of patients reported as or clinical outcomes for non-diabetic CKD patients. Now, core KDCO recommendations for iron supplementation recommend starting iron agents in anemic patients with non-diabetic CKD patients, goal of either reducing ESA doses or obtaining an increase in hemoglobin levels with a trial of either iron, oral or IV iron for patients with T cell less than 30% and ferritin less than 500. Iron supplementation, what are the adverse effects? Well, if you talk about the oral iron therapy, then there was a GI tolerance and constipation side effects in many patients. They have been found. IV iron form are associated with an enhanced oxidative stress, endothelial dysfunction, and infections. And IV forms are associated with increased risk of hypotension, headache, or hypersensitivity reactions. But in newer population, that iron isomaltoside or ferric carboxymaltose, these side effects are reduced to minimum. Oral form may cause gut dysbiosis. So iron supplementation, iron first approach. Iron first approach recommended by CITA guidelines. Iron supplementation reduces ESA requirement, increases hemoglobin. Recommended by Anemia Working Group of the Spanish Society of Nephrology, administration of IV ferric carboxymaltose in patients with CKD, heart failure, and reduced ejection fraction and iron deficiency, even in the absence of anemia. So, even if anemia is not there, you correct iron deficiency and it will lead to an improved cardiovascular outcome in the CKD patient. So, iron first approach, there are some meta-analysis, affirm AHF study, FAIR HF study, and these all uh, concluded that iron supplementation or iron correction should be done in CKD patients with iron deficiency, even in absence of anemia, and this will increase the quality of life of the patient and will reduce the ESA requirement and will maybe lead to a optimal hemoglobin level. Now, newer therapies are coming up, which are oral therapies, which are HIF-PHIs, hypoxia-inducible factors, plural hydroxylase inhibitors. And what is their mechanism is that they address the interplay between iron metabolism, alkalosis, and inflammatory state. They reduce the inflammation, reduces the hepcidin level, and they also increases the life of endogenous erythropoietin, so less requirement of blood transfusion. Stable hypoxia-inducible factors within the cell, they stabilize hypoxia-inducible factors within the cells, inhibit the action of chloride hydroxylase, which leads to an increase in the levels of HIF and therefore to an increase in endogenous erythropoietin, stimulate the transport of iron, even they means they also help in the correction of the anemia chronic kidney disease due to iron loading within the cell. So stimulate the transport of iron from the enterocyte and macrophages into the circulation, and in the phase 3 trial, there are a lot of molecules, roxadustat, daprodustat. There, they can be administered orally, and differences there. All these molecules having some differences in pharmacokinetics and thermodynamics. So these are the various forms of HIF-PHI, which are on the study: roxadustat, vadadustat, daprodustat, moldustat, and there is a difference in the HIF alpha selectivity Roxadustat is HIF1 alpha and 2 alpha. Vadadustat is HIF2 alpha greater than 1 alpha. And other two are HIF1 alpha and 2 alpha. And they are in phase 3 clinical trials. And in 2019, roxadustat have been approved in Japan, with other vadadustat, daprodustat are ongoing phase 3 trials, and moridustat is in phase 2. Now, what is the efficacy of HIF-PHIs? The phase study, Dolomite study, and phase 3 trials are going on, and they have good outcomes in increasing hemoglobin levels even after 9 weeks of treatment. Roxadustat was non-inferior to darbepoetin alpha in the achievement of hemoglobin response during the first 24 weeks of the treatment, and vadadustat showed non-inferiority to maintain hemoglobin levels within the target range, associated with an increase in the total iron binding capacity and a decrease in the heparin level. So they are anti-inflammatory also. And this is the summary of the various recent and ongoing trials on roxadustat, vadadustat, and dapagliflozin. So safety, we can say that they are quite safe if we see about the correction of anemia, rising of the hemoglobin, is increase in the endogenous EPO is in the physiological range. Rate of adverse event related to high EPO levels should be expected to be lower than with ESA, such as thrombosis, fistula thrombosis, or some cardiovascular events. It modulates many non-erythropoietic agents, EPO genes. They improve iron utilization, LDL, LDL lowering effect, ischemia protection, and a protective effect on CKD progression. But there are some adverse events also, because it is potentially deleterious side effects due to the modulation of other genes. There may be tumor progression, may enhance vascular calcification, worsening of retinopathy, increasing the pulmonary artery pressure. These things growth this is maybe uh, long-term studies will tell how much of these side effects are of the clinical importance. So in summary, just I would like to summarize that CKD is extremely common with a prevalence of 10%. One in every 10 people is having some form of CKD, and is some form of chronic kidney disease or kidney disease. And anemia is a common complication in patients with CKD. The severity of anemia increases with CKD progression. Anemia and CKD are associated with reduced quality of life, worse renal survival, and increased morbidity and mortality. Up to 60% of the patients with non-dialysis CKD develop anemia. 50% of patients with non-dialysis CKD have iron deficiency. Management of anemia in non-dialysis CKD patients involve the use of erythropoietic stimulating agents and iron supplements. And recently, hypoxia induces factor prolyl hydroxylase inhibitor, which is HIF-PHIs, is involved as a potential therapeutic agent for anemia in non-dialysis CKD patients. While several clinical trials are ongoing, a few studies have established its efficacy, and available data suggests that they are efficacious and safe alternatives to ESAs with several potential advantages over current therapies. However, more data needs to be confirmed with trials regarding the safety of their use in the CKD and patients. So thank you for your patient hearing.